Shall I start? All right, well, great. Well, thanks to everyone who's joining us this evening for this webinar. I will say before we get started, if you'd like to participate in Q&A during tonight's discussion, please enter your question, including your graduating year, if that is applicable, into the Q&A box at the bottom of your screen. It will be visible to the facilitator. If your question is selected, we will ask the question on your behalf. Please submit those questions at any time during this presentation. And then for optimal viewing, please enter full screen mode. So that's my public service announcement to get started. My name is Margaret Robison, Columbia College class of 1990. I am honored to be serving as the president of Columbia College Women, the alumni organization for Columbia College. Our purpose is to amplify the voice and contribution of women in the college through outreach programming, mentorship of students and alums, and the Columbia College Women's Scholarship. And I'm so happy to be introducing our panel for tonight's discussion. The moderator is my good friend, Dr. Lisa Dabney. She is also Columbia College class of 1990, assistant professor at Mount Sinai Medical School, Department of Obstetrics and Gynecology, where she's been a faculty member since 2000. Lisa's a native New Yorker. She got her BS in biochem from Columbia in 1990 and her doctorate from UCLA in 1995. And she's actively involved in teaching residents and medical students. So she will be helping us by moderating this evening's conversation. Also joining us is Kim Mutcherson. She got her BA from Penn and her JD from Columbia Law in 1997. She is the co-dean and professor of law at Rutgers Law School and is a reproductive justice scholar who focuses on assisted reproduction, abortion, and maternal fetal decision-making. We're so thrilled to have her. And last but not least, Dr. Gary Nobert, who is the parent of Columbia College 1990 student. He is an OB-GYN in Avon, Connecticut, got his medical degree from Tufts University School of Medicine and practiced for over 50 years until this past June. During medical school at Boston City Hospital, he first became aware of women suffering from sepsis and became involved in advocating for women's health pre-Roe decision, was involved during the tenure of Roe and throughout the last few years until June. He was teaching residents at Hartford and Yale. He worked closely with Connecticut Planned Parenthood, and he retired officially in 2007, but continued to work with Planned Parenthood and the Yale Medical School in the area of abortion care. So that's my introduction for our wonderful panel. I'm going to turn it over to Kim, who is going to start with some history of the legal implications, and we will have hopefully a wonderful discussion. Thank you all for joining us.
All right, let me get everything doing what it's supposed to be doing. Yep, okay, perfect. Thank you so much for the introduction, Margaret, and thank you so much for having me here. I'm really looking forward to our discussion today. So I am the JD, not the MD on this panel. So my job is to talk about the law. And that's what I'm going to do to get us started. I'm going to talk in pretty broad strokes, but obviously we're going to have time in Q&A. So if you have any questions, please feel free to just drop them into the Q&A. So I want to start off very broadly in thinking about how the state has regulated parenting and procreation in this country. So starting with Buck versus Bell, the 1927 case, where the Supreme Court said it's perfectly okay to sterilize people if we think they shouldn't be having babies. And then Meyer versus Nebraska and Prince versus Massachusetts, which were cases that said that we have a fundamental right to the care, custody, and control of our minor children. Then Skinner versus Oklahoma in 1942, which found that there's a fundamental right to procreate, but in doing so did not overrule Buck versus Bell. So that remains good law in this country. Griswold versus Connecticut and Eisenstadt versus Baird, the first saying that there's a right to access birth control for married folks, and then the second that there's a right to access birth control for single people. And then finally, really the focus of our conversation today, Roe versus Wade and Planned Parenthood versus Casey, which initially said that the Constitution of the United States conveys a fundamental right to terminate a pregnancy. So I want to talk about Roe first, because I think it's really important to understand exactly what has been lost and when we started to lose it. So Roe, of course, was decided in 1973. This is Norma McCorvey, who was Roe in Roe versus Wade. She was a young woman on her third pregnancy, wanted to have an abortion, lived in Texas at the time, and Texas would not allow you to have an abortion unless you got a panel of physicians to say that the pregnancy was a risk to your life. So she became the plaintiff in Roe versus Wade, and Roe, the Supreme Court, in a 7-2 decision, decided that there's a fundamental right to an abortion that can be found in the Constitution. They decided that a fetus is not a constitutional person. They also said that the state has an interest in potential life, but didn't sort of sort out what they meant by that. And then they created the trimester framework. And in the trimester framework, they said that states cannot regulate abortion in the first trimester because their interest in potential life isn't great enough at that point. In the second trimester, they can regulate, but only to protect the health of the pregnant woman. And then in the third trimester, states can go so far as to ban abortion, but any ban has to have an exception for the life or health of the pregnant woman. So that was the law until 1992 in Planned Parenthood versus Casey. And Casey is really when we started to see the Supreme Court significantly scaling back. There were some other cases in between about abortion funding, but Casey is where the court really said, actually, we're not so sure that we feel good about Roe v. Wade. So in Casey, the court upheld the constitutional right to abortion, stopped talking about it as being a fundamental, and they rejected the trimester framework and they replaced it with the viability line. So they said, we're no longer going to say, you can't regulate in the first trimester, you can in the second, and you can even ban in the third trimester. We're just going to focus on the idea of viability, and that's what our dividing line is going to be, which of course means that you have a line that is not a fixed line because viability shifts. So rejected the trimester framework, replaced it with the viability line, expressed concern that Roe didn't give enough weight to the state interest in potential life, which is a big part of the reason of why they rejected the trimester framework, because they wanted to make sure that states had more power to assert their interest in potential life. And they also said the state interest in potential life starts from the moment that a pregnancy begins. And that was a really big shift for them to go in that direction. And then they created this new standard for deciding whether a law was constitutional or not, which was the undue burden standard. And I'm not even going to go into details on that because they destroyed it. So after Casey, the court basically said, and this was a Pennsylvania case that had to do with Pennsylvania's Abortion Regulation Act. So they said that spousal notification or consent, that is unconstitutional. You cannot require a married woman to seek the consent of her husband or to notify her husband before terminating a pregnancy. So that was a good thing. But other forms of regulation, they said, were fine. Waiting periods were fine. So 24 hours, 48 hours, whatever number really that you came up with. Because again, the state has an interest in potential life from the moment that a pregnancy starts. And if the state has a right to try to dissuade a pregnant person from terminating that pregnancy. And waiting periods ostensibly are a way to get people to rethink their decision to terminate a pregnancy. Biased informed consent requirements. So not just what do we tell people because it is medically sound information, but states requiring things like saying, having an abortion increases your breast cancer risk. Things that are actually not actually true, but requiring physicians and other healthcare providers to say those things before an abortion could happen. Parental notification, that was an acceptable regulation. But there always had to be a judicial bypass. So there always had to be an opportunity for a young woman to be able to go in front of a judge and prove that she was mature enough to make the decision to terminate a pregnancy. Of course, the irony is that if she's not mature enough to terminate a pregnancy, then apparently she's mature enough to actually become a parent. So after Roe and Casey, this is basically what abortion law looked like in the United States, that there's a right to privacy. It is broad enough to encompass the right to terminate a pregnancy, and it is constitutionally protected. A fetus is not a constitutional person, even if the state has an interest in fetal life. You cannot ban abortion before fetal viability. If you do have an abortion ban, it has to include an exception for the life and health of the pregnant person. You cannot require spousal notification or consent. And if you require young women to notify their parents, then you have to create an opportunity for a judicial bypass. And then the 2022 Supreme Court term happened, and they basically blew up everything, but particularly everything that had to do with abortion. And so, given the opportunity in Dobbs versus Jackson Women's Health, which was a case coming out of Mississippi, the court decided essentially, oops, where's all my Dobbs language? Oh, my Dobbs language disappeared. Well, what that slide should say is the court decided basically that there is no constitutional right to terminate a pregnancy, and there is no such right because the word abortion doesn't appear in the Constitution. Neither does the word woman, neither does the word privacy, neither does the word family, but we'll put all of that aside. And it's not an enumerated right in the Constitution. They also said that it's not a right that can be read into the Constitution because it is not a right that is deeply rooted in the history and traditions of the United States. And they said essentially, we're going to throw this back to the states. So every state gets to make its own decision about whether abortion is going to be legal and under what circumstances. And then what they also really threw into great confusion is all of these things that I was saying before, right? There's no longer this right to privacy. We're not sure whether a fetus is a constitutional person. Maybe it will become that now. Certainly you can ban before viability because we threw away Roe and Casey. There's no sense that an abortion ban has to include an exception for the life and health of the pregnant person anymore. Not clear that spousal notification can't be required. And it's not clear what's going to happen in terms of young women and abortions either. So there's lots of stuff that has happened post-Dobbs, and I'll just run through just a few of the things really quickly. Obviously, lots and lots of clinics have closed and more will. This is a picture from the Pink House, which was the Mississippi abortion clinic, the last abortion clinic in Mississippi, which is now closed. And there are lots of states now that are losing any of their remaining abortion clinics. We know who gets hit hardest when abortion gets banned. 75% of folks who have abortions in this country are low income. Most of them already have a child or children at home. Most of them are young. They are in their 20s, and a disproportionate number of them are women of color. So we're seeing things now like refusals to fill prescriptions and states that are actually trying to make it illegal to fulfill prescriptions for the pills that are used for medication abortion, even though those pills are also used for other kinds of ailments. Questions about where the next generation of abortion providers are going to come from, because where can you get training? Questions about what's going to happen to women who either self-manage their abortions or who are thought to have tried to self-manage their abortions, and what is going to happen to those folks. So I'm going to leave it there, but there's obviously lots more to talk about here, and I will turn it over to Lisa.
Okay, thanks, Kim. That was great. So let me try to share my screen. So as everyone's aware, this is pretty devastating consequences. And what I wanted to give you was a brief talk of like what this actually means and what OB-GYNs are thinking about and what a mess this all is. So let's see. Does that work? Can everyone see that? Okay. Hopefully this was, so this is kind of a crazy slide, but you know, it's been almost 50 years. We almost got it to 50 years, and our phones have gone from the corded varieties to basically a computer in your pocket that landed a man on the moon. And yet we seem to be going backwards in women's healthcare, which is just sad. So 50 years of case law was overturned with Dobbs. Overnight, women in almost half the states had their rights curtailed. And this really is horrible for physicians and women because it really interferes with the sacred doctor-patient relationship. We now have lawyers and administrators coming between doctors and their patients. The psychological and social impacts on women are devastating and profound. And it's really what I want to spend is how this really affects women's health. So abortion care is an absolutely necessary part and aspect of women's health care. Pregnancy can be risky, and abortion, especially done by a trained provider, is generally much, much safer. Well, what are the numbers? Well, the case fatality rates of pregnancy are now much better than they were, 1 to 2 per 10,000 women. The case fatality rates of abortion are 1 in 200,000 to 300,000. So there are about 300,000 to 400,000 abortions a year. It varies depending on how you count it. In 2018, 2 women died of abortions, and about 700 women die in childbirth each year. And granted, we have more births. There's between 3 and 4 million births each year. But the bottom line is the case fatality rate of pregnancy is 20 to 40 times that of an abortion. So these are critical numbers that people need to know. And it's even worse for women of color. These are just some, the little details are not important, but the most important thing is these are deaths per 100,000 live births. These are overall women, and these are Black women and Hispanic women and Black women who, again, are disadvantaged patients who are not getting access. These are the women that are not going to have access to abortion, and now you're sending them into a far riskier endeavor of carrying a full-term pregnancy. So why is pregnancy risky? Well, what are the issues here? And most of it, what you need to understand is it's the risk of infection. And the pregnant uterus and the pregnant woman is much more susceptible to infection, mostly because women during pregnancy, their immune systems are somewhat suppressed. They have to carry something that is other, that is not of them. So they need to have suppressed immune systems so that their immune system does not attack the growing embryo and fetus. And this all boils down to, you probably, if women who've been pregnant will hear about like the mucus plug that's lost during pregnancy. That plug forms at the time of conception, and it prevents and protects the uterus from infection coming from the vagina. And it's this loss of mucus plug that then heralds the onset of labor. But if the membranes are ruptured, or there's premature rupture of membranes, or there's a miscarriage, the risk of infection is great. And this is something that went on for centuries before the modern era. So, for example, in the 1850s, in the mid 1800s, this woman here, her biggest risk of pregnancy was infections. 50% of women who died in childbirth died of infections. By the 1970s, the risk of infections had gone down. And heart disease, interestingly, now is like the #1 killer of women who die in childbirth. Infections are still important, but it was really bringing these risk of infections down that changed and markedly reduced the risk of maternal mortality. So an interesting story about this was the largest drop in infection happened when an Austrian physician named Semmelweis discovered that women on the midwifery ward had a much lower rate of what was called puerperal fever, which is basically infection of the pregnant uterus, than those women who were delivered by doctors, because the doctors were doing autopsies and then immediately going into childbirth and not washing their hands. I know it sounds crazy, but this is what happened. And he was the one who first said, infections are what are killing women and we need to wash our hands. And so he instituted, this is a great graph, and you can see these are super high rates of puerperal fever and infections, but they instituted chlorine hand wash here, and then it dropped off markedly. And the rate of maternal mortality continued to decline from the 1920s onward with the advent of antibiotics, with the development of blood transfusions, with the ability to recognize a lot of these conditions. But this drop really began in the mid-19th century. So this is kind of all-cause women's mortality, but you see how kind of mirrors like maternal mortality. This spike is the 1919 flu pandemic, but it was really the drop in maternal mortality that brought down the risk of death for women. And so it's so critical to understand this, and it started with hand washing, but understanding the risk of infection is critical to everything else. So, so what is an abortion exactly? Maybe, you know, the medical procedure is known as a D&C or D&E. It includes the dilation of the cervix, because you have to open the cervix, and then removal of the pregnancy. Curettage is with a sharp instrument, and evacuation, it's usually done with sort of a suction device. And this is what this is in display depicts here. This would be an early pregnancy where we have these kind of manual evacuation devices with gentle suction. You open the cervix just a little bit and you can remove the pregnancy, which is very, very teeny in the first trimester. And it's really important to understand what the medical terminology around abortions are. So the definition, medical definition of an abortion is a termination of a pre-viable pregnancy or a pregnancy that is less than 22 to 24 weeks. And then we break them down, us obstetricians, in different types of abortions. So complete spontaneous abortion, otherwise known as miscarriage. That's someone has an early miscarriage, they miscarry at home, they might not even seek medical care. An incomplete abortion is when part of the pregnancy has been lost, but some tissue still remains inside. And an inevitable abortion is the pregnancy is not viable because the cervix has dilated early in pregnancy or the membranes have ruptured. The embryo may still have a heartbeat, but again, once that cervix opens up, once the membranes are ruptured, that woman is at risk for infection. That pregnancy, if it's pre-viable, is not going to ever go to term. And a therapeutic abortion, and this is popularly known in the lay press as what we call an abortion or a voluntary termination of pregnancy. What is so critical for people to understand is the procedure, number one, generally doesn't get treated. Like I said, that's your standard miscarriage has been completed. Number two, an incomplete abortion. Some women can complete these on their own, but if they cannot, the procedure for 2, 3, and 4 is exactly the same. Exactly. So it's very important for people to understand what it means to lose abortion providers. It's also really important to understand that fetal heartbeat does not equal viable pregnancy. Like I said before, in an inevitable abortion, the cervix has dilated, and then maybe the membranes have ruptured or not, and there could still be a heartbeat, but there is no way that pregnancy can be saved. There's also things called ectopic pregnancies, in which the pregnancy is growing outside of the uterus, can also be a heartbeat. This pregnancy is not viable, cannot be saved. Both of these conditions can lead to bleeding or infection and possible life-threatening sepsis, or even hysterectomy if the conditions are not treated promptly. And now we have hospital administrators and lawyers that are dictating care in these incredibly sensitive cases. And I just want to do a little aside about ectopics. So this is just showing different places that a pregnancy can implant. It can implant in the ovaries. Most of them implant in the tubes. They can implant in the corner of the tubes, in the cervix, or even completely outside of the reproductive organs. I know, and these are probably extreme cases, there's been talk of like, oh, well, maybe we could remove the pregnancy and move it somewhere else. That is impossible. This pregnancy is not viable. And I think even in these states where they have these restrictive abortion laws, most hospital administrators, and there's not a lot of debate about treating ectopics. There are horror stories, but for the most part, there's not a lot of a debate. But sometimes there's really fuzzy type of situations, such as something like this. So this is what is known as a C-section ectopic. And this is a woman who had a prior C-section, and then she has an embryo that develops. But that embryo doesn't sort of in the endometrial cavity, but not really. It implants into the C-section scar. Now, there's a lot of controversy even now because our ultrasounds have gotten so good that we can pick up these pregnancies, which we probably even 10 years ago could not distinguish between this being a C-section ectopic versus being a normal viable pregnancy. And the recommendations are to terminate this pregnancy because if it is not terminated and it grows in the wrong place, it can form what's called a placenta accreta, which is an incredibly dangerous pregnancy that will leave a woman with potentially losing the pregnancy and losing her uterus at the same time. These are incredibly complicated, difficult decisions that can only be made between a doctor and a woman and her doctor. And the idea that these cases are being subjected to panels of administrators is incredible to think about. So there is one good thing that is very different and that has changed in the last 50 years, and that's the abortion pill, or mifepristone. So what is that? What is mifepristone? It's been around since 2000. It was approved by the FDA then. It's 93 to 95% effective at any pregnancy if used within the first 70 days, the first 10 weeks of pregnancy. It blocks progesterone is how it works. And progesterone is the hormone that's needed to develop an embryo and a placenta. And it's then used with a drug called misoprostol or Cytotec, which is a prostaglandin analog, which then the mifepristone stops the pregnancy from growing. And then the misoprostol helps the uterus contract and get rid of the pregnancy. So you can kind of think of it as like sort of an opposite of Advil. It works that way. And misoprostol has been around for a long time. Originally was a drug used to treat ulcers. So the crazy thing, and what has recently been changed, was when mifepristone first came on the market, and I apologize for the slide being so busy, but it was subjected to this FDA plan that is risk evaluation and mitigation strategy. And they decided at the time, and probably is more political than anything else, that despite the long-standing safety record, it was subjected to medically unwarranted what's called REMS, risk evaluation mitigation strategy, which was imposed by the FDA by the drug's approval in 2000. This medication, since 2000 until recently, could only be dispensed by certified providers. Patients had to sign agreements. They were told about the potential side effects, and they could only be dispensed in clinics, medical offices, and hospitals, not retail pharmacies. During the pandemic, the FDA changed these rules to allow some flexibility, to allow mailing of pills to patients without being seen. And this month, the FDA decided to officially, finally remove this restriction so that mifepristone can now be available in pharmacies and dispensed like other medications. And studies have shown, many studies now have shown, that no test medication abortions are safe and effective up to first 10 weeks of pregnancy. No test medication abortions means basically you can have a telehealth visit and they can just take a history. They don't need to do an ultrasound. They don't need to do an exam and that will hopefully increase access, at least for certain women. And this has already started to happen. So this graph shows in 2000, when mifepristone first came on the market, it accounted for very few terminations, and now it's well over 50%. So in conclusion, it's really important to understand that abortion care and the procedures involved in abortion care are a critical component of women's health care. Surgical and medical abortions are much safer than delivering a full-term pregnancy, 20 to 40 times as safe. And hopefully medical termination and mifepristone and some changing laws may alleviate some of the impact, but that certainly remains to be seen. So thank you, everybody. So I think for the last part, before we're going to do the questions, I was just going to kind of go through Gary Nobert, who is also my father-in-law, and is maybe some of the reasons why I went into the field that I went into. But he has had experience practicing obstetrics and gynecology through all of this, before, during, and you know, and through all the changes. So I think it'd be helpful just for him to give us some insight, just sort of like what experiences he had. So Gary, why don't you I know you kind of gave me some anecdotes, but just kind of briefly talk about what it was like and what your experiences were being an obstetrician and gynecologist in the 60s before the advent of Roe.
Well, I was at medical school in Boston in the early 60s. My junior year, I had obstetrics at St. Margaret's Hospital, which obviously they didn't discuss contraception or abortion. And then in my last year, which was 1965, early in 65, I was at Boston City Hospital, and there I was shocked to see women coming in with septic, meaning that they were already far along in infection, septic abortions, which in those days were referred to as criminal abortions, because these were usually done by back alley abortion persons, not usually doctors. Things like potassium permanganate, which was a little cautery that you could do, we would see burns on the cervix in these patients. I think that one of the points that I wanted to make is that part of the reason these patients were seen so late was the idea, the stigma that was around the term criminal abortion. I mean, that was the term that was used in the 60s. And
meaning that they were afraid of, like, they'd have legal ramifications or be arrested.
Right, yeah. Who's the criminal? And then I went to my residency in June of 65, and there, as was alluded to by Professor Mutcherson, it was illegal for me to discuss contraception with patients at that time, and certainly not abortion. It was illegal. And I was called with the other residents to the autopsy room, where a 17-year-old Black girl was on the autopsy table. And what had happened is, what was interesting for us was that someone had used a coat hanger, inserted it into, or attempted to insert it into the cervix, where Lisa was showing how there's a block plug there. And what they did was slash the lining of the uterus. It turns out that a pregnant woman has a very negative venous pressure, and she apparently took a deep breath and had an air embolism and dropped dead immediately. And so what was interesting was all these bubbles in the vena cava and the heart, and there she was on the table, dead. And I don't think anybody, I don't know that the police even were interested in this. Was a minor who someone had killed her in the process of attempting to do an abortion.
So you don't know if, like, she was
Yeah, we don't know anything about
her.
her, and I don't remember any discussion about that whole issue. And it struck me that as I was in training, taking care of these women, and in Hartford Hospital at that time, throughout my residency, which ended in '69, we were taking care of, just like Boston City Hospital, women who were coming in with infected abortions. They were horrible cases. Operating on them, many would die in the process. we would have to do what we called a clean out. We would have to take the uterus and ovaries out in order to stop the infection, and then hope that they would survive. And so that treating criminal abortion and septic abortion was a big deal. There were courses about that. And that all changed, of course, when Griswold versus Connecticut came in when I was in the second year of my residency. Now, sepsis is rare, but not zero. And because of antibiotics, lessening the stigma of abortion and better blood availability, abortion is very central, as Lisa pointed out, to women's reproductive rights, and therefore all of women's rights. And in fact, there are men involved in this. It isn't true that all of these women are alone. And so that this is an issue of privacy in making decisions about your own body, something that I was very sensitive to. And as I had discussions with patients about decision-making about abortion or not, I learned that there was a big difference in women and men. Basically, I used to watch women in labor and think, there is no way in hell I would let that happen to my body. and so that, you know, I had a rare view because I was spending a lot of time, not only in my private practice, but with Planned Parenthood in the decisions, the many variety of decisions involving abortion.
So, hey, Gary, Kim was asking, just, do you know, back when women came in the 60s and they were suspected of doing illegal abortions, did anyone try to prosecute them or find out like who was?
No.
Okay.
The onus was, you know, doctors, and I was aware, by the way, that there were some private physicians in those times who would say a woman was bleeding, therefore threatening to abort. And you have to remember, this is before ultrasound.
Yeah.
And they would take them in and do a DNC on them. And these were not inner city women. These were patients who could afford to talk to.
You mean they were kind of coming up with a reason to fix the miscarriage when it was really—
That's correct. Yeah. So that there wasn't a law against emptying retained products of, in other words, there are parts of the pregnancy that are remaining, as you pointed out, in incomplete abortion, and doing a DNC on that. So who's to say that if someone is bleeding, that she isn't just threatening to abort, or that it's already too late?
The administrators were not getting involved.
They were not. No, this was purely a doctor patient.
Interesting. You know, why don't you talk about a little bit about, I mean, I kind of mentioned again, you know, women who came in with, especially in the second trimester, with an inevitable abortion, which is basically a woman who came in with ruptured membranes and the cervix is dilated and they're only 4 months along.
Right.
What sort of procedures were you doing back then?
Well, in the 60s, what you had to do was an abdominal operation, basically a mini cesarean section. And
because you were worried about infection and you didn't want them to.
They would try to use medication to cause the pregnancy to spill, which was difficult because that had to be done in the hospital, and the nurses got involved and they were upset, and we were stopped from doing it because it caused so much of an uproar in the hospital.
Just because they would have to sit there and watch these women kind of miscarry.
Right. It might take 2 or 3 days.
Right. Yes.
And so I didn't learn how to do the surgical evacuation of a uterus, that is, using a suction and forceps to remove a later or farther along pregnancy, until the mid 80s, when I became involved in a clinic that was doing those. We transferred our abortion services at Hartford Hospital to a private clinic because it was causing so much disruption amongst the anesthesiologists and nurses who were anti-abortion, and we were having lots of problems with that. So we began doing them as an outpatient, and there I learned how to do second trimester abortion at first without ultrasound, and thank God in the late 80s we began having ultrasound to do it because we had to use our sense of feel for that.
Were
What
those
happened
techniques not available? Oh, sorry.
pardon?
Were those techniques not available in the 60s at all? Like no one
No,
was
they
really
were
doing
not.
them.
They were not available. Basically, what we were doing was
Yeah.
different methods of trying to get the uterus to go into labor and expel
Yeah.
the fetus, which of
Yeah.
course didn't always work. And
Right.
then you had to do a mini cesarean section. So it wasn't until the 80s that we began doing the surgical interventions. And one of the cases that I think was quite poignant, and it shows the issue of how integral this is to women's care in general. I was called by a professor of obstetrics at the University of Connecticut, and what had happened is a patient at St. Elsewhere had ruptured membranes at 18 weeks, and they had spent 5 days trying to medically induce her labor. And by the time she was brought to the University of Connecticut, she had a temperature of 105, was very critically ill. And the professor said to me, "I've never learned how to do this. Could you come in and help?"
Hmm.
He didn't know how to do that. So the issue of, as a general obstetrician, you're going to face this kind of problem, even if you don't do abortions.
Yeah.
And so I came in, and fortunately, we were able to successfully evacuate this pregnancy, and her infection subsided, and that went on. So I see this as important. When you brought it up, there are a number of hospitals, including Johnson Memorial in Connecticut, just recently announced that it was going to stop doing obstetrics. Now, that's a hospital that's about an hour and a half away from Hartford or Yale, any level 1 hospital that can take care of very seriously ill patients. And they were stopping obstetrics because they couldn't find nurses or doctors who were able to do it. And there was another hospital in Connecticut and several elsewhere. Just yesterday, or the day before, Ann Richards was being interviewed on the University of Roe versus Wade, and she said that ultimately there will be states in which no providers are available who know how to deal
Yeah.
with what she called troubled pregnancies.
Right. I think that the issue of kind of, and these are, again, this goes beyond even, like the first trimester, women who seek first trimester abortions, it's still going to be problematic. I think that it'll be interesting to see how will change that. But what is very important to get across to everybody out there is that the techniques for managing early and mid pregnancy losses are the same. And if we are not training our doctors, our gynecologists, our future gynecologists to do these procedures, women are going to go back to getting infections from a second trimester loss. They're going to go back to getting hysterectomies from a second trimester loss, because this is such a critical component of women's healthcare and gynecological care. I think that it's how the surgical procedures have changed, and how trying to regulate this is problematic on many levels, even beyond the whole psychosocial aspects of it, which are profound. I'm just kind of focusing on the medical aspects of it.
Yeah, and I think one last comment is, and I wanted to stress this, is when you talked about ectopic pregnancies, how the heck that ever got lumped in together with abortions is a puzzle to me, because these are non-viable pregnancies.
Yeah.
They will not succeed. And if you don't do something about them, either treating them early medically or surgically, the woman will die. It was the most common cause of dying from bleeding in pregnancy when I was a resident in the 1960s.
Yeah.
Because we didn't have early diagnosis with ultrasound, and pregnancy tests were not positive until 6 weeks of pregnancy.
Right.
So that women could have ectopic pregnancies, which got to the point of rupturing, and then what you have is a woman coming into the emergency room hemorrhaging internally, and you've got to rush her to the operating room and take care of it.
Yeah. Yeah, absolutely.
But that's not an abortion. I mean, that's a
No.
real that's how doctors are being tied up in this. Doctors are afraid to decide what to do about that in certain states
Yeah.
because the laws are so vaguely worded that they can be criminally as well as civilly sued for trying to do the right thing for these women.
Kim, did you want to have any questions for either one of us? You might be a good person to start off with.
I don't know that I was taking a bunch of notes just because I was sort of thinking through a lot of things as Gary was speaking. Sort of thinking about questions of miscarriage, mismanagement, right, which we're already seeing. If a healthcare provider, if there's still a fetal heartbeat, I cannot perform an abortion, right? People sort of thinking that way, and what the risks are to the pregnant woman when you're just waiting, because that's what you think the law is telling you to do. Also, I was thinking a lot about how dangerous abortion stigma has been here, right? There's a reason why so many abortions take place in clinics and not in other medical settings, and that's because, as Gary was saying, people got pushed out of hospitals.
Yeah.
Right. And so it has become this incredibly stigmatized and dangerously stigmatized procedure. But I guess the big question for me, or one of the big questions for me, is this sort of last piece, right? Because what you said, Gary, was with an ectopic pregnancy that you are not performing an abortion. And one of the things that I think has been very interesting is watching people who are anti-choice advocates define different things, right? So deciding that, well, there's no law that keeps you from performing any kind of procedure for an ectopic pregnancy because that's just not an abortion. Or on the other side of it, saying anything that potentially keeps a fertilized egg from implanting in a uterus, that is an abortion, right? So we see them going after Plan B because they see that as a potential abortion. And one of the things that I'm sort of really curious about is, what expectation do you think that we should have of people who are in the profession, right? ACOG usually says something. AMA actually has said something post Dobbs, which was sort of surprising. But it feels to me like advocacy from physicians and other healthcare providers is actually really important here, but that doesn't necessarily seem like something that you get taught in medical school, right? How to be an advocate.
I mean, ACOG is pretty, and there's ACOG is the American College of Obstetrician and Gynecologist, and then they have an arm called ABOG, which is the boarded specialty that controls our boards, that certifies OB-GYN.
Don't they require?
And they have come out and said, we are not changing the requirements. You need to train. Your program will not be certified if you don't get training in abortion care. And this is critical because teaching hospitals in this country get a lot of money from the federal government. And if they lose just one resident a year, that is a lot of revenue loss. And so everyone is scrambling, kind of figuring out where to send, trainees now so that they can get their training. I think another really interesting thing to look for is we're in between medical students interviewing for residency and the match, which comes out in March. And I think that programs that are in these states are going to have a lot tougher time finding quality medical students, because why would you go train in an OB/GYN program where you can't learn? And again, I want to stress, it goes beyond learning abortion care. It goes into micromanaging, administrators micromanaging how we care for our patients, which does not happen. I mean, the most amazing thing I tell my trainees is that when you're finished your residency and you're board certified, nobody is looking over your back. You have such really freedom and responsibility for your patients. People do not question what you do unless you're starting doing crazy stuff. But the fact that there's administrators kind of telling doctors how to practice medicine is mind-boggling. Like, this doesn't exist in any other situation.
I never practiced in a state where that was true, and neither did you.
I mean,
when
I don't think I could practice down
was
there. I think they're going to lose a lot of OB/GYNs because although there's, and then some people say, well, that's not fair to the women, you're punishing, which is true. I mean, there's two ways to look at this. But the OB/GYN community is pretty upset. This is just a funny aside, but we have to go take oral boards each year, and the oral boards are in Dallas, Texas. They've built a building there. And for the past 2 years, all the trainees are sending around this petition saying, I will not go to Dallas. Number one, I could be pregnant. I don't want to get my medical care down there. Number two, I have abortion on case law. What if I get arrested? So there is a lot of stuff happening behind the scenes. But it's tough, I don't know. It's just mind-boggling.
Yeah.
So
can you touch
Margaret,
on Lisa, can you touch on the fact that men are not applying for residencies? Maybe most people don't realize it, but when I was in training, there were 0 women gynecologists, 0.
Yeah,
I took in the practice. We turned out our first woman in the late 70s, and I took her into practice and the second one into practice with me. And so that was a gradual change. And even in 2007, our residency program was mostly 50-50 or 60% women and 40 men. Now I think Lisa tells me that's drastically changed, which cuts the number of applicants in half.
Yeah, I would say that it's been about 70% women, kind of my generation and younger it's mostly women. So Kim, why don't you talk a little bit about how this might impact like fertility treatments? Because that's a whole other thing I didn't even go into. There's so much to discuss.
Yeah, definitely. So, one of the things that I said was that what the Supreme Court's decisions in Roe and Casey did was they sort of cabined, at least in some way, the state's interest in potential life, right? You couldn't ban abortion before viability. You couldn't ban abortion if the pregnancy was a risk to the life and health of the pregnant woman. So there was some sense of a balance there. And we no longer have that, right? We no longer have the U.S. Constitution and the U.S. Supreme Court saying there's a threshold below which you cannot sink. And so it's not really clear what states are going to do with that power. So if a state decides that, an embryo is as much potential life as a fetus, and we want to protect embryos as much as we want to protect a fetus, then if you're a person who's, a fertility provider in that jurisdiction, you're going to have to figure some things out, right? So when they say to you, you can't keep thousands of frozen embryos because those are children and they should be brought to fruition, what does that look like? Could a state actually force somebody to give up an embryo for embryo adoption, right? Which already happens in this country. Could a state make rules about how many embryos can be created during an IVF cycle? Could a state make rules about whether you can do a selective reduction for somebody who is, pregnant with 4 and only wants 2, and it's safer to only carry 2 instead of 4. The state could say, well, that's the roll of the dice, and we'll see how it goes. So, there are these sort of interesting and problematic ways of thinking about how, given how states already interfere in pregnancies, how states will now feel, frankly, emboldened to extend their interest in not just what's happening inside of somebody's body, but what's happening with an embryo that is outside of somebody's body. And just to give you an example, Arizona passed a law some years ago about embryo disputes. And basically what they said in that law was, if there is a dispute with 2 parties over an embryo, that the embryo should go to the person who is willing to try to bring that embryo to fruition, which is completely different from what every court that has ever had to decide an embryo dispute pretty much has said. And then the next thing they said was, if both people want to use the embryo, then the embryo has to go to the person who is most likely to have success in bringing that embryo to fruition. So what is that supposed to mean, right?
Wow.
So if you're a 45-year-old woman, but your ex-husband says, I will hire a 25-year-old surrogate to carry this embryo, then does he get it and you don't get it? And why should a court be making those decisions anyway? Right. So there's a lot to be sorted out, and it does create a lot of pressure, frankly, on fertility providers, because the informed consent process, right? So normally in an informed consent process, for instance, for IVF, you would say, let's decide what's going to happen with your embryos if you guys divorce, or, if you have extras left over, and here are your options. Your options are donate to research, you can destroy them, you can have them adopted by somebody else, you can keep them frozen in perpetuity. The state could step in and say, donation to research cannot happen. Destruction cannot happen. Keeping them frozen in perpetuity cannot happen. And now, as the healthcare provider, you have to say to folks, well, if you have extras, you're either going to have to use them, or you're going to have to give them to somebody else. And that's not a conversation I think that most reproductive endocrinologists want to have with patients.
Do you know if any ones come through with those laws, any of these states? I mean, because that would just
not yet. We're too early. We're too early, really, right? And part of what we're seeing right now is states just trying to figure out what they can do on abortion, right? I mean, so we've got litigation going in dozens of states already. And we've got, state legislators who are sort of saying, what's the next piece on the agenda, right? So Plan B is definitely on the agenda. Medication abortion is on the agenda, right? There are already efforts to shut that down in particular jurisdictions, or to punish people for mailing pills. There's a can't remember, it's a state in the Midwest, can't remember which one of the I's, where they're trying to pass a law that will make it illegal to dispense the pills that are used for medication abortion. I mean, so there's a lot that's going to be going on over the next few years, both in the abortion space and then, broadened out from there as well.
I was listening, or there's definitely some groups like in states like New York and Connecticut, where they're passing sort of laws to protect providers, and they're trying to figure out how we can mail abortion pills to these states. And because New York won't extradite them.
Right.
But then if they go down there, could they be arrested? Like,
right.
What is the legal community kind of talking about with those?
Yeah, I mean,
ideas?
so what, one of the questions that came up at the oral argument in Dobbs, was this concern about, can states criminalize conduct that people engage in outside of the state, right? So if I get an abortion in New York and then I come back to Georgia, can I be arrested for that? If I am an abortion provider who's providing abortions in New York, and then I come to Georgia for something, can they arrest me because they know that I perform abortions elsewhere? If I mail pills to Georgia, can I be arrested for that? And so honestly, that's going to end up in more litigation, right? As states decide, if states try to control how people travel, to criminalize out of state conduct, those are issues that raise all sorts of constitutional concerns. So even the idea, part of what the Supreme Court said was, we're getting out of the abortion business, which is ludicrous because there are so many issues that are now, the life or health exception. Can a state pass a statute that says if you're pregnant and that pregnancy is killing you, sorry, but you're going to die? Right? I mean, that's outrageous to think that you could pass a law like that, and yet it's not clear that you can't. So, I've been saying, sort of jokingly, but it's actually really true, the real winners in all of this are lawyers, because we're going to be kept busy for years to come with all of the litigation that is happening here. It's outrageous. It's
That
absolutely
gets into the question of minors and rape. These laws about having both parents. I mean, I worked at the only clinic in Connecticut that put patients to sleep. And so we had a higher, as opposed to sedation that wasn't fully asleep. I mean, you take a 13-year-old who's been raped by her stepfather or father and brought in by an aunt or another person. You can't even examine that person until you put the patient to sleep. Thank God for ultrasound. And so now you're going to start forcing these minors to have the parent, perhaps the rapist, get involved in the decision. And there are famous cases that are being talked about, but they are not that uncommon.
Yeah.
I mean, our clinic saw the majority of those patients. And so I think this is another horrific thing we're going to start hearing stories about in these other states.
Yeah. And many of these new abortion bans, either new bans that have been passed or bans that were not being enforced because they were pre-Roe bans, don't include exceptions for rape, for rape or incest. And then some include, and you always have to be suspicious of, how this happens in a state legislature. There's at least one state legislature where they decided that they would have an exception for rape, but not for incest. And I don't know that I want to know who was making the argument that incest is okay. So there's, the other piece of this, and this is what I think is also really critical. The people who are making these laws are not healthcare providers. No. Right? They're not doctors. They're not nurse practitioners. No. And so, they're adding all this language that makes sense. They're making up words. It's just, it's incredibly and so difficult, right, for people to practice medicine when they are being told what to do by people who have no idea how to practice medicine.
Right. So someone brought up a question in the chat. So they wanted to add, they're asking how the lack of access to abortions, particularly in clusters of southern states, affects wait times for women to receive the care they need on the patient side of things, and how this is affecting or overwhelming providers in states that are still providing abortions on the provider side of things. I mean, I think there's a couple of different aspects to this, and I think it depends on where you are practicing. So I work at Mount Sinai, and we made a big deal. We have a large family planning division, and we made a big deal about how we were going to make sure that we gave care to women. And we've seen a little bit of an uptick, but not much. But who's really getting hit? The border states like Illinois,
Pennsylvania,
like anywhere where they're near states that have restrictive access. That is absolutely affecting it. That women who live in those states, the waiting times to get abortion care has definitely gone up. And, a lot of these women also, again, it's not just, they're having first trimester abortions. They're women with complicated pregnancies, women with fetal anomalies that are now traveling, long distances. So It is definitely affecting different areas, but it depends on, it's whether or not you're a border state, like Colorado, Illinois, New Mexico, Pennsylvania, Western Pennsylvania are being affected by this a lot.
Right. Right. And that's, that's only going to get worse, right? So the prediction is that by the end of, a year post Dobbs, that about half the states, maybe 25 to 26 states, will have significant bans, either total bans or bans. Oklahoma's ban says abortion is banned from the moment of fertilization, which is just like the dumbest, right? Just say it's a ban, right? Or, 6 weeks in Georgia, or 15 weeks, in other states. So, about half of the states will have that. And the only reason why we don't have more now is because of litigation. But that's also causing confusion. So, on Monday, you can't perform abortions, and then there's an injunction, and on Tuesday you can, and then the appeals court overrules the injunction, and on Wednesday you can't perform abortions anymore. I mean, I don't know how you practice medicine, or how you make decisions about your pregnancy in that kind of a constantly shifting and confusing environment.
Yeah, I mean, I think
that's where we're going to be for a while.
Yeah. There was just an article this week in the Times about how in these states where there are exceptions for rape and incest, essentially you still can't find providers because a lot of them are just leaving.
Yep.
And the ones that are left, the doctors, they don't want to put their license on the line. And they're just like, what if, some
or
judge
their freedom.
Yes.
They could go to prison.
Yeah, they could go to prison. So like doctors are essentially just saying no because they don't know what to do.
Yeah.
They're scared. It's really bad.
Yeah. And I sort of suggested this before, but I want to really be clear about it. The other thing is putting a healthcare provider in a position where you know what you should do. You know what the standard of care is.
Yep.
And the law tells you can't do it.
It's again, you take the Hippocratic Oath, first do no harm. I mean, it goes against every fiber of what being a physician is. So, it's awful.
Yeah. Yeah.
For everyone involved. So.
Do you have any more questions? Oh, there's Margaret.
Okay.
We have another, so I'll let you.
Okay. Yeah. I see. All right. I was born a month early and had a fight for my life. Isn't viability argument a lie? Not sure what you're getting at, but viability has pretty much been at 22 to 24 weeks, and it hasn't really changed much in the last basically my entire time I've been practicing medicine. And that's because the lungs don't really form until 24 weeks. That's like the final thing that forms. Babies still, it hasn't changed. Like the chance of a 23-weeker surviving is incredibly low, and it's almost non-existent for 22 weeks. So that viability line, even though it's a little fuzzy, it's pretty hard and fast set.
There's also the neurological development.
Yeah. Yes.
Well, for instance, almost all of the babies born at that 23 weeks will have eye problems, which are
yes.
And it isn't until about 28 weeks where you're out of the woods.
Yeah. Yes, there's the risk of disability is really high, especially.
And you're right that those statistics, I thought that was interesting because our maternal fetal medicine used to bring those statistics to our department every year, and I was really surprised at how it didn't move the needle.
No, it hasn't changed that much. So
most of my practice.
Okay. And the second question, I've opposed Roe since I learned in law school about the trimester argument. Also, my whole life, I believe we have human constitutional rights to do to our bodies as we wish. With or without doctors or certainly government's approval. I think we all agree with that. The right to use any drug we want, right to suicide or even assisted suicide. All right. Well, that's a whole other discussion.
Right.
But agreed.
Right. Which we don't have a constitutional right to.
Right.
The Supreme Court has been very clear about that.
Okay, is it illegal to send abortion pills to a state that bans abortion? I'm leaving that for you, Kim. I don't think,
Not yet.
not
yet.
yes.
So there are definitely states that are working on it. And it's certainly illegal to use those pills, right? So,
Interesting.
you know, if you get them there and then somebody uses them, there's potential criminal liability there because
For
you
the
have been
patients, for the woman?
well, see, so here's the other thing that we haven't talked about. So, you know, it used to be, and Gary, you talked about this a little bit, right? Which was if, you know, if a woman had an illegal abortion, she was never punished for that, right? I mean, so the anti-choice movement had for a very, very long time taken this position that women were, you know, victims of the abortion industry. And, you know, we don't want to punish them. We only want to punish the people who provide abortions. But in part, because of medication abortion, that's just not a tenable position anymore, right? I mean, people can self-manage abortions. They can do so safely.
Yeah.
You know, people can buy pills from overseas and have them shipped here, right? So the idea that you will only continue to punish providers is totally going to go out the window. We're already seeing states who are, you know, making changes to their homicide laws. So that if you self-manage an abortion, you're a murderer and you can be arrested for that. Yeah.
Really?
So, I mean, that's just,
Wow.
if your goal is to keep everybody possible from having an abortion, you cannot just punish abortion providers anymore. The ability to terminate has just shifted enough that you're going to have to start punishing women. And that's what states are going to do. And some of them are already starting to try.
Wow.
Yeah. It's a bad future ahead of us.
Yeah. Yeah. Let's see. So.
Well, going once, going twice on questions, but we, I think we've taken a lot of all of your time and really appreciate the thoughtfulness on this topic, which is very, very fraught with a lot of misinformation and emotion. And as you said, Lisa, I mean, it just kind of goes against what everything you've signed up for when you became a doctor. So I appreciate all of your insights. Kim, Gary, and Lisa, thank you guys for your time and for agreeing to join us today. Thanks to everyone who has joined the webinar. We appreciate it. We have some other CCW events coming up. We'd love to have you join. February 9th, we're going to partner with the Alumni Talk series, which you may be familiar with, and have a conversation on Black women's history and Barbie, and specifically around women's entrepreneurship. We have Alayla Bundles, who's a journalism school of 1976 graduate and trustee emeritus. And so that should be a really fascinating conversation. We actually have the individual who creates the Barbies and some other great people involved in that. And then on March 2nd, we just had to shift the date. I believe it's now March 2nd. We're going to have a virtual artist talk with Aya Agawa, who's Columbia College class of 1997, and they'll be discussing their play that's opening in DC shortly after. And I hear they've been nominated for an Obie, so it's going to be a pretty interesting conversation. We hope you all can join both of those. And not last but not least, our signature event for Columbia College Women will be happening on March 25th in the afternoon. Mark your calendars, come to New York City. It's going to be an afternoon of entrepreneurship, starting with a rapid fire pitch contest where we call it the Lion's Lair. So it's our version of Shark Tank with some Columbia entrepreneurs pitching their businesses. We're going to have a fireside chat with mine and Lisa's college classmate Nancy Pack interviewing Kathleen King, the founder of Tate's Bake Shop. Nancy was CEO of Tate's for a while, and she's going to be interviewing Kathleen about her experience building that business. And then we're ending it up with cocktails and bites and some pop-up shops by some other Columbia entrepreneurs. So it should be a fascinating afternoon, and we hope you all can join for that. And once again, thanks to all of the panelists, and thank you all for joining this evening. Have a good night.
Good night.